Hello everyone. This is a case of a 12-year-old boy who presented with blunt trauma injury over his head. His MRI was done, which revealed T1 isointense and T2 hyperintense heterogeneously enhancing biconvex lesion measuring 25 into 19 into 27 mm in the left anterior parietal bone in the paramedian location, just posterior to coronal suture. This lesion showed subtle peripheral restriction diffusion. The lesion was displacing the dura and abutting the left frontal lobe without contagious involvement or significant vasogenic edema. You can see these are the intraoperative findings. The lesion appears to be well circumscribed. This is what we received in the lab, soft and bony tissue pieces. Histology revealed presence of fibrocollagenous tissue showing dense diffuse infiltration by Langerhans cells, macrophages, lymphocytes, plasma cells, and abundant eosinophils. The Langerhans cells are oval cells having, you can see here, these are reniform to convoluted nuclei at places showing cleaving. The nuclear chromatin is fine and you can see presence of inconspicuous nucleoli. The nucleus is slightly eccentrically placed and the cytoplasm is abundant and pale eosinophilic. You can see abundant eosinophils in the background. In our case, bony infiltration was present and occasional multinucleated giant cells were also present. We did immunohistochemistry and the histiocytes were positive for CD68, S100 and the confirmatory marker, that is CD1A, you can see it's very strongly positive, confirming the presence of Langerhans cell histiocytosis. BRAF V600E was negative and the Ki67 proliferation index was 15 to 18%. So, diagnosis of Langerhans cell histiocytosis was confirmed. It is basically a clonal proliferation of Langerhans cells type cells manifesting in the central nervous system or the meninges with or without systemic lesions, which pathologically correspond to its counterparts occurring elsewhere. It is commonly found in children, age group less than 15 years, and the male is to female ratio is 1:2. Localization, most common CNS involvement is craniofacial bone and skull base, almost 56% of cases, with or without soft tissue extension. Intracranial extraaxial masses are also common, particularly in the hypothalamic pituitary region. In meninges, they account for 30% and choroid plexus 6%. A leukoencephalopathy-like pattern with or without dentate nucleus or basal ganglion neurodegeneration is observed in 36% of patients with Langerhans cell histiocytosis. Clinical features: patients have present with circumscribed tumor-like lesions, and such patients have acute or subacute, non-specific, or location-dependent neurological. Patients with neurodegenerative-like lesions present with a chronic or slowly progressing neurological pattern combining cerebellar syndrome, pyramidal tract signs, pseudobulbar palsy, and/or neuropsychiatric symptoms. Imaging findings: X-ray is very typical, well-defined, punched-out lytic lesions with sclerotic borders. The MRI reveals tumor-like lesions that are characterized by one or multiple masses. They are hypointense on T1 and hyperintense on T2. Gadolinium infusion shows contrast enhancement. The diagnostic criteria laid down by CNS WHO 5 are: The essential criteria are: the population of cells should show cytological features of Langerhans cells and should express CD1A and or Langerin, that is CD207. And in the desirable criteria, S100 positivity, BRAF and MAP2K1 mutation status should be present. Coming to diagnostic molecular pathology, 50% of cases show BRAF V600E mutations and 25% of patients show MAP2K1 mutations. Prognosis, prediction and treatment. Tumor-like lesions are sensitive to conventional anti-tumor treatments, including vinblastine and cladribine. And in cases where you find a molecular marker positive, such as MAPK signaling pathway inhibitors, may be given, and such patients have favorable prognosis. In contrast, neurodegenerative lesions are resistant or poorly sensitive to multiple therapeutic strategies, including radiotherapy, differentiating agents, immunosuppressive drugs, cytotoxic chemotherapies, and molecular targeted drugs. Neurological symptoms tend to worsen slowly over decades. Thank you very much.